Okay, can everybody hear me? So just checking the chat. Colleen says yes. Rosa says yes. Luke says yes. Excellent. So I think we'll probably kick things off. We are slightly early, but we've got a big audience of delegates today, which is excellent. So thank you all very much indeed for joining us this evening for this month's film reading session. Before we get on to the cases, just a little introduction for those of you who haven't met me. My name is Ian Jones, and I'm a radiologist. I graduated from the RVC back in 2004, and I got my imaging certificate in 2009. I completed my residency at the RVC in 2016, and I got my diploma back in 2018. And if any of you guys want to get in touch with me, then this is where you can find me. So I'm at London Veterinary Specialists, which is a multidisciplinary referral hospital right in the heart of North London. And if you'd like to get in touch to have a chat about a case that you think might benefit from imaging, and you're just musing over which study would be most appropriate, or if you have some radiographs or some ultrasound images that you'd like a hand with, then please feel free to drop me a line, either via telephone or on email at that email address. So hopefully you guys have all had a chance to review this month's cases. So 4 cases per session. You should spend no more than about 15 minutes per case during your review. When you're reviewing the cases, the idea is to provide a radiographic description of all the abnormalities that you think are present, and then conclude on those abnormalities. And if you think that it could be any number of different conditions, then order your differential list with the most likely at the top and the least likely at the bottom, and be able to justify those differentials and the order that you've selected. And if you think that that patient might benefit from some additional imaging, so for example, if you have some abdominal radiographs and you think there might be a foreign body or a mechanical ileus, and you think an ultrasound would help, then recommend an abdominal ultrasound for that patient. Sometimes there'll be some additional images to help us along our way that I have access to, but you won't have had access to up to now. So that can certainly help stimulate some additional discussion around these cases. So before we begin, we'll just look at an example. So this is a case that we evaluated a few months back. So it's a 5-year-old male neutered ridgeback that's presented to you with unproductive retching. So for this case, we just have a single right lateral abdominal radiograph. And hopefully you guys can appreciate that the stomach is really markedly dilated and it's predominantly filled with gas. We've got some compartmentalization of the stomach here as well, as evidenced by these soft tissue bands that are bisecting the gastric lumen. And the shape of the stomach looks very abnormal. So the smaller, more tubular pylorus is in a dorsal location relative to the lumen and the antrum. So that's a big concern. The other thing is that the spleen looks a little bit displaced, so we wouldn't necessarily expect the spleen to be quite as dorsal as that. Other changes would include things like the caudal vena cava being a little bit smaller than we might expect. Now, other things that we can look at and comment on, given our suspicions for this patient, would be the gastric wall. So given that we are suspicious that this stomach is abnormal and this dog could have a GDV, we should look for signs of any gastric wall necrosis, as evidenced by gastric pneumatosis, so gas within the gastric wall. And the gastric wall here, I think, looks pretty normal, so there's no evidence of a gastric pneumatosis. We don't see any convincing evidence of a megaesophagus or a paralytic ileus in this patient. So a lot of dogs with GDVs, they'll have big dilated loops of small bowel. That'll be as a result of a paralytic ileus rather than a mechanical ileus and obstruction. In dogs like this, and in all dogs that present with retching or vomiting, it's always just worth checking out the caudoventral thorax just to make sure there's no evidence of an associated aspiration pneumonia, and that looks normal. So our conclusions here would be that this dog has, as a GDV, we've got this classic Popeye arm-like appearance of the stomach. So if you guys are familiar with Popeye, then this is Popeye's hand, and this is Popeye's bicep, and this is the forearm, and this is where we'd expect the anchor to be. So it looks like Popeye's arm, so it's definitely a GDV. This patient would require surgery. So your recommendation would be that this dog goes immediately to the operating theatre after being stabilized cardiovascularly appropriately. So that's an example. So hopefully that's the only one this evening that I'm going to have to present for you guys. So these sessions are very much based around you guys having the opportunity to discuss these cases. So it's very much an interactive session. These patients are not in any danger. These are all historic cases. It's not an exam. So this is a friendly, relaxed environment for us to share our knowledge and our ideas about radiographic interpretation. So hopefully at least 4 of you guys will be prepared to share your thoughts on some of these cases this evening. I think if you do one case, then you shouldn't have to do another case. So one case per delegate, and there are only 4, I think is fair. So let's move on to case number 1. So case number 1 is a 1-year-old male neutered domestic short-haired cat that's been involved in a road traffic accident. So does anybody fancy presenting case number 1?
I'm happy to have a go if you can hear me.
Yep, I can hear you.
Okay. So on the first X-ray, we've got a right lateral and a VD view of the caudal abdomen and pelvis of a skeletally mature cat. So on the lateral view, I can see that there is a good serosal detail in the abdomen from what I could see on the pictures, and the bladder looks intact. So I think there's a reduced chance of any free fluid, but I'd still want to check that, but I'll talk about that later. Yep. The spine looks all to be intact on this view, but obviously everyone's seen the other view. The pelvis, I would say on the lateral view, obviously you haven't got the best positioning, but we know why when you look at the other picture. And then there is a bone neoplasticity caudal to the pelvis, which I think is like a chip fracture. So moving on to the VD view, obviously the right side of the pelvis. I went with the word luxation because I know they're meant to be joints rather than the actual bone as a fracture, so I've called them luxations. So I said there's a right sacroiliac joint luxation, yep. As well as luxation of the pubic symphysis. So on the right side, the ilium is displaced laterally and the ischium is displaced medially. The pelvic canal doesn't look too narrowed to me. Okay. The acetabulum on the right side looks intact, and I don't think there's a fracture there. Obviously, the tail looks like it's been disarticulated after the sacroiliac joint, and that is displaced to the right laterally. What else did I find? Oh yeah, and then obviously you can see the bony opacity again on this side, just caudal to the left side of the pelvis. And then the femur the femurs both look okay. I can't see any other fractures. I can see some kind of foreign looking object over the top of the left femur. I'm not sure whether, yeah,
this thing here.
Yeah.
Yeah, okay.
I wasn't sure whether it was a pulse ox or what it was.
Yeah, I think it's probably a drip line.
Okay, yeah. So what I've concluded from it is there is luxation of the whole side of the right pelvis and a tip fracture on the left pelvis and a tail pull injury. So my recommendations were an AFAST to check or like the abdomen to make sure, because obviously there's been a trauma, so you don't want to just base it on x-rays that there's no free fluid and no damage to anything in the abdomen. And also I'd probably want to make sure that all the nerve function in terms of urination, defecation and locomotor function of the limbs and things was all working okay before deciding on a prognosis for the cat. But the canal doesn't look too narrowed, which is a good thing in terms of for the colon, but obviously I'm worried about a lot of nerve damage.
Yep. Okay, yeah, fabulous. Nice job. So I think you've done an excellent job of describing all the radiographic changes here. So as you suggested, this right hemipelvis here is displaced cranially and medially. It's a little bit rotated as well, which is why it looks so strange in the lateral view. You commented on the fact that there is ever so slight narrowing of the pelvic canal here, which I thought was great, and also the fact that we've got this right sacroiliac luxation as well. You mentioned this bony opacity here. I think that's probably the left tibial, the left ischial tuberosity, and we could probably describe this as an avulsion fracture because there are a couple of muscles that originate from here. I think the semimembranosus and semitendinosus originate from here. So that we could describe that as an avulsion fracture. The main thing really that you picked up on is this tail pull injury. So I think this is pretty tricky to see in the lateral view because we've got superimposition of the first sacrococcygeal vertebra and the sacrum. So there's not really a huge amount of dorsal and ventral displacement of this tail relative to the sacrum. It's superimposed, so it's tricky to see here. But in this VD view, we can see that this tail is definitely displaced to the right relative to the sacrum. So there's definitely a tail pull injury there as well. I like the fact that you commented on the bladder and the peritoneal serosal detail. So we know that this cat has been involved in a road traffic accident. So it's important to try and decide whether we think the bladder is intact or not. And I like the fact that you've recommended abdominal ultrasound just to follow up on that. We can see the bladder here, so chances are it is intact, and I think the peritoneal serosal detail is okay. The only other thing that we could maybe have commented on is the abdominal wall. So occasionally you can get abdominal wall ruptures in cats that are hit by cars, and this abdominal wall looks like it's intact in the lateral view. It looks like it's intact as well in the VD view. So absolutely, we've got a right SI lux, we've got a left ischial tuberosity avulsion fracture, and a tail pull injury. So yeah, nice job. Well done picking up the tail pull. That was the thing that I wanted you guys to spot in this case. Does anybody else have anything to add for case number 1?
I have a question, Ian.
Yeah.
On radiographs, do you have any tips to know whether the pelvic canal is in danger or not? Like if you see this radiograph, it looks like it's not narrow, but do you have any kind of measures whether you think it may be compromised? Yeah,
there aren't any objective ways of measuring the pelvic canal to decide whether it's too narrowed. So it's always subjective. I think for cats like this, the proof will be in how the cat responds following treatment. So if the cat goes on to have problems defecating, then by definition that pelvic canal is too small for that colon and rectum to function normally, and that could potentially be a problem ongoing. But there aren't really any objective measurements that I can say to you guys other than to sort of eyeball it subjectively, and if it looks like it's going to be too narrow for the poop in the colon and the rectum to fit through, then it's likely that it's going to be a problem. But I'm not aware of any papers that say if the pelvic canal is less than 50% of what you would consider to be normal, then this patient is likely to go on to have problems and have trouble defecating and be constipated. It's very much more a subjective thing.
Cool, thank you.
Okay, anybody else have anything else to add about this case? Okay, everybody happy? All right, so let's move on to case number 2, which is a 6-year-old male entire Cocker Spaniel that's presented to you vomiting. So who fancies taking on case number 2? And there are lots of people to choose from.
I can do it if you want.
That would be lovely.
Just to let you know, it's really tricky, this case, at least to me.
Yeah. So yeah, this one not as straightforward as the last one.
Definitely no.
Okay. All right.
So we have 2 views. One is a left lateral projection, and the other one is a VD projection of a skeletally mature dog, the abdomen of a skeletally mature dog. And can you go back on the lateral? Sorry.
Absolutely.
Okay. There are no abnormalities within the musculoskeletal part considered in the study. What we can see is that there is a subtle loss of serosa details within the abdomen. There are gas-filled, I think, small intestinal loops. We can see a sort of rounded shape, ball shape, gas field, which I think is the pylorus.
Yep.
And it seems attached to it. We can see 2 sort of inverted U-shaped gas field loops. I'm thinking maybe the duodenum, but I'm not totally sure.
Yeah, no, I could buy that.
Okay. Between these 2 loops, there is another gas field with amorphous material, which I may think it can be the transverse colon.
Okay.
And we can follow it through his hand, and we can see there is pretty the same amorphous material within. The liver silhouette is within the costal arch. We can see the tail of the spleen on the ventral part of the abdomen. There are some fluid small intestinal loops in the mid-caudal part of the abdomen. The bladder looks quite big also, and there is a mild dorsal displacement of the colon of the caudal part of the colon. And then I cannot see the kidneys, because they are essentially the gas filled duodenum is border efface them. And regarding the VD projection, I'm not sure if has been taken like in a second time, or if has been taken like straightforward to the lateral, because essentially I cannot really follow the gas filled duodenum that I can see on the left lateral, and I'm not totally sure if this, sort of comma shape, C shape, is part of the ileocolic junction. I'm not totally sure, to be honest.
Okay.
And I cannot follow also the transverse colon in this projection.
Yeah.
And also there is a moderate to severe loss of serosa detail of the caudal part of the abdomen. So it's a bit tricky to distinguish, the essentially the abdominal organs.
Yeah.
So I'm not really sure if this is foreign body or I'm not sure if an abdominal ultrasound in this case it would be beneficial due to the quantity of gas. So, or if the dog is stable, we can reassess him in another 24, 48 hours.
Okay.
Repeat the radiography.
Okay. So what would be your conclusions here?
I mean, if that one is duodenum and we check for the typical measurement, I'm not sure if they would be more than 1.6 or 7, 8, the 8 of L5. I don't know, probably try with an abdominal ultrasound and check.
Yeah, no, I think that's reasonable. Now we don't have any ultrasound images for this patient, unfortunately. So we're going to have to rely on the radiographs. But I think it's reasonable here to say that an obstruction is possible, but we're not quite sure at the moment. Just out of interest, and you guys can join in via the chat. How many of you guys think that this dog is obstructed and should go to surgery? And how many of you guys think that we should sit on it and see what happens? And part of sitting on it might include doing an abdominal ultrasound. So let's just see if we get any responses from the chat. So Colleen thinks that it could be a foreign body and it could be a ball. So presumably Colleen is a little bit concerned about the appearance of the pylorus here.
Definitely.
Sheldon is also a little bit concerned that the gas pattern within the bowel could represent an obstructive pattern and mechanical ileus. Caesar is going all out and saying that this dog is obstructed and needs an X-lap. So is Jacqueline as well. So about 50-50 still. A few of you a little bit braver and saying that, yeah, let's crack on and let's open this dog up. And we've got tons of responses on the chat now. I'm struggling to keep up. Alice has said she'd go for an abdominal ultrasound. Maita is concerned about this bladder, and I agree that the bladder is kind of big, but I mean the bladder is a storage organ, and sometimes it's big and sometimes it's small, and I think this is just a dog that kind of really needed a wee. Giorgio suggested that a pneumocolonogram would be helpful, and I think that's true. So we can see the descending colon here, so we're pretty confident about identifying the descending colon in the lateral view, and I think this is a DV view, which is why it's pretty useless, to be honest. I agree that it's tricky to really confidently identify really many of the abdominal organs, and it's really tricky to see what's going on in this right cranial abdomen, particularly related to what we can see in the cranial and dorsal abdomen in the lateral view. So a pneumocolonogram might help. It might help us to identify the colon and be a little bit more confident about whether the mottled radiopacity we can see in the mid-abdomen represents fecal material within the transverse colon, or whether that is a piece of small bowel and maybe it's filled with some foreign material like fabric that could be causing an obstruction. So if we come back to the radiograph, there's a couple of things here that I would be a little bit concerned about. So I think there are two distinct populations of small bowel here. So we've got a bunch of small loops of bowel in the mid-ventral abdomen that are reasonably small. And then, as you described, we've got a whole bunch of small bowel within the cranial and dorsal abdomen that's a lot bigger and that is filled with gas. And the distribution of this bowel is a little bit abnormal. So it all seems to be kind of bunched in the craniodorsal abdomen and a little bit stacked up as well. So you're describing the distribution of these gas-filled loops of bowel as looking like inverted U's. And I think that's because there's some stacking of the small bowel. This structure here, because this is a left lateral, I think is the pylorus. I think it's a gas-filled pylorus. It's not really consistent with a ball foreign body. I agree that this structure that we can see just extending dorsally from this pylorus is most likely the duodenum. And for me, that does look quite chunky for a duodenum. So the fact that we've got two distinct populations of small bowel, that we have some loops of small bowel that look dilated, some loops of small bowel that look relatively empty, and we've got stacking of the small bowel as well, means that I would be concerned that this dog could have an obstruction. Now, the thing that makes it challenging here is that it's really tricky to see the foreign body, and for the life of me, I couldn't see the foreign body looking at either of these radiographs when I was evaluating them for the first time. So My recommendation here to the clinician was, I'm pretty sure that this dog is obstructed. I'll just stick the probe on quickly and see if I can see the foreign body. I couldn't find the foreign body with the probe for whatever reason in this patient, but the sonographic changes mirrored what we can see on the radiographs. So on the ultrasound, I could see two distinct populations of small bowel. One was really big and filled with echogenic reflux and ingesta, and the other was completely empty. So this dog had an XLAP, and it was obstructed, and it had a corn cob in it. So the answer here is that this dog did have a mechanical ileus, it did have a foreign body obstruction, and the foreign body was a corn cob. Now, I've gone back and had a look at these radiographs since then to try and test myself, and can I actually see the corn cob in these radiographs? And I think it is extremely difficult. I'm not sure I can see it at all in this lateral view, and the only thing that I can see in this DV view that might be a corn cob is this little structure here. So we've got a structure here that is outlined by gas, and it has a corrugated appearance. It may not be the corn cob, but that would be my best bet in terms of trying to identify the foreign body on these radiographs. If any of you guys have any other suggestions as to where the corn cob is, and if you can see it, then that would be great. But that would be my best guess, is that this structure here, it looks almost rectangular. You can't really see the right and the cranial margins of it, but just medially you can see this boundary that has a soft tissue opacity, and it has this corrugated appearance that you get with corn cobs, and then a little bit of gas around it. So that could be it. Now, I didn't expect you guys to see this and nail this down and say, this dog is definitely got a mechanical ileus and it's definitely got a corn cob, because I mean, I'm not completely convinced that is the corn cob, and whether you can see it in these radiographs. But the things that I wanted you to pick up on were the fact that there's two distinct populations of small bowel. One is full of gas and the other is completely empty. The distribution of bowel is abnormal, so it's all kind of bunched in the craniodorsal abdomen, and we've got this stacking of the small bowel. So those are all things that would concern me and make me think that this dog could absolutely be obstructed and have a mechanical ileus, and at the very least we should either do an abdominal ultrasound, or we should hang on to this guy and take some repeat radiographs to see what's happening in this craniodorsal abdomen with all these loops of distended bowel. So yeah, that was a much more tricky one. Is there anything else that I thought you guys should comment on? No, again, occasionally in these vomiting dogs you'll see some aspiration pneumonia. The cranial thorax looks okay in the lateral, and the thorax, and we've got a lot of the thorax in the DV, and that looks okay, so there's no evidence of pneumonia. So yeah, nice job. Much more tricky than case number one, but I think that's probably going to be a theme this evening. I don't remember what I've put as case 3 and 4, but yeah, nice job. Okay. Anyone have any other questions or anything to share about case number 2?
Can I ask you, where was the foreign body? Was it in the ileus?
I think it was jejunum, if I remember rightly. So I think it was just past the caudal flexure of the duodenum. So if it was in the duodenum, then I'd really hope that we could see it here. But I think it's in here somewhere. It's just at the start of the small intestine, just beyond the caudal flexure of the duodenum.
Okay.
But I didn't think it was absolutely nailed on. As I say, the recommendation I made to the clinician was that I'm very concerned that this dog is obstructed and he's going to need an XLAP. Let me just stick the probe on, and I couldn't find it on this dog for whatever reason. All right. Anybody else have anything to share? Any questions? And you can do that by using your mic or via the chat. All right, great. Let's move on to case number 3. So case number 3 is a 3-year-old female neutered Maine Coon presented to you with vomiting and dyspnea. Okay, who fancies taking on case number 3?
I'll have a go at it, sure.
Great. All right.
For my sins. God, maybe I'm barking up the wrong tree, but from looking at it, musculoskeletally, I didn't see too much wrong. That all seemed fine. The things that stood out for me, obviously, is feces in the descending colon, a loss of detail and just serosal detail in general, particularly ventrally and cranially, and some unusual collections of gas pockets, particularly in sort of the ventral aspect of this X-ray, questioning. I wasn't saying it particularly associated with any loops of bowels. So I was querying whether there was free gas in the abdomen.
Yeah.
And also dorsocranially, the fact that you have the diaphragm effaced either side by gas, suggesting that there's gas in the abdomen to cause that shadow. So I was questioning whether there was some sort of septic process, like septic peritonitis with gas production, either from the bowel or from bacteria.
Okay.
No, obviously the liver, stomach, it's very hard to gather exactly silhouettes of any of the viscous because of what's happening with fluid accumulation.
Yeah. All right. So what would be your conclusions here?
Conclusions with it. The loss of detail makes obviously free fluid in the abdomen seeming highly likely, plus also with the potential of free gas in the abdomen. Again, I would go to scanning plus or minus tapping if fluid was found.
Yeah.
I was concerned about some sort of septic peritonitis allowing for sort of free fluid in the abdomen plus free gas.
Yeah. Okay. No, that's great. And yeah, I absolutely agree. So I think there is absolutely a loss of peritoneal serosal detail here. So we can just about make out the margins of the liver and the stomach, and particularly in the mid-abdomen here, it's really tough to see any of the margins of any of the small bowel or the spleen. Now, what's more concerning is this unusual distribution of gas that you've described. So in the mid-ventral abdomen here, we've got a couple of little gas accumulations, and it's difficult to really convince yourself that these little pockets of gas are within the bowel. So immediately you start seeing little gas bubbles that look like they're floating in the peritoneum. You need to be very concerned because this cat could have a pneumoperitoneum. And we don't necessarily need to rely on these more subtle gas bubbles in this cat because, as you pointed out, we've got beautifully well-defined margins for the diaphragmatic crura, and we've got gas opacity in between the diaphragm and the cranial border of the liver here, so that there's absolutely gas here. This all represents gas as well. We can see the margins of the stomach here beautifully, and that's because we've got this soft tissue opacity of the gastric wall against the gas that is in the peritoneal cavity. So there's a whole bunch of gas here in the cranial and dorsal abdomen, and then we've got some gas that's just edging along the diaphragm in the cranial abdomen, and then a whole bunch of little gas bubbles that we can see in the mid-ventral abdomen with an associated loss of peritoneal serosal detail. So you're absolutely right to suggest that not only do we have gas here, it's likely that we've got some fluid here as well. And the changes that we can see in the right lateral are very similar to the changes that we can see in the left lateral. So again, we've got a very poor peritoneal serosal detail in the mid-abdomen, and then we've got a whole bunch of gas just outlining the diaphragmatic crura in the dorsal and cranial abdomen, around the kidneys, and potentially in the retroperitoneal space as well. So a pneumoperitoneum, absolutely, non-specific peritoneal effusion, and the fact that we've got gas within the abdomen would suggest that there's been some sort of leak somewhere. So if you see gas in the abdomen, either it's external air that's gone in or it's internal air that's come out. There's nothing that we can see to suggest that this cat has a musculoskeletal problem or a penetrating injury to the abdominal cavity that might have contributed to the gas that we can see in this abdomen. So it's much more likely that this is internal air that's popped out. Yeah, and in terms of the usual suspects, something like a perforated GI tract would be top of the differential list here. Yeah. It's not really clear why that's happened, so we're not really seeing any evidence here of a foreign body or a mechanical ileus, but certainly the combination of loss of peritoneal serosal detail, non-specific peritoneal effusion, and a large volume pneumoperitoneum is a big worry, and something like a GI perf would be very high on the list here in terms of what's caused this. Does anybody else have anything to add in terms of our initial radiographic assessment here?
I just had a quick question, if that's all right, Ian.
Yeah.
so kind of before Shell kind of presented it, I didn't spot that gas kind of at the top. I was just looking at that kind of ventral, those ventral bubbles that you were describing. Yeah. So I guess in this one it's probably not useful, but do you ever kind of find it useful to do those kind of horizontal views to try and differentiate if it's free or not? I thought that could be an option.
Yeah, absolutely. So I mean, if for example you were looking at a very small volume peritoneal effusion, and sometimes that's just going to manifest as a focal accumulation of gas within the peritoneal cavity. And if you have a patient that has a small volume pneumoperitoneum as well as peritoneal effusion, it can be really tricky to try and decide whether or not that gas bubble is just a bit of intestinal gas that looks a bit funny because there's fluid within the peritoneal cavity and a raging peritonitis, so all of the mesenteric fat is very inflamed, or it's a pneumoperitoneum. And that is really going to influence what you do. So if you have a patient that has a pneumoperitoneum, that patient needs an XLAP. There really isn't anything else you need to know before taking that patient to surgery. Whereas if it's just a bit of gas within the bowel, then it's possible that you could manage that patient medically, whatever the cause of the loss of peritoneal serosal detail. So it's super important to be able to tell the difference. And the horizontal technique is absolutely something that can help. So either you can do it would be a VD view with the patient in left lateral recumbency, or you can use the dorsal technique, so have the patient in dorsal recumbency with the cranial abdomen slightly elevated. And if you guys are interested in finding out a little bit more about those horizontal techniques, we posted a webinar not too long ago that explains exactly how to obtain those horizontal beam projections. You do need to be able to move your X-ray tube, which is not always possible, but those horizontal beam techniques can be super useful. So if you're interested in finding out exactly how to do those, then yeah, you can check out our webinar, which is I think it's the radiographic approach to the acute abdomen. So yeah, horizontal beams would have not for this case. So we don't need it in this case because the volume of gas is sufficient for us to be super confident that there's a pneumoperitoneum here. But if it's a much smaller volume, then yeah, absolutely.
And diagnostic peritoneal lavage as well, if you were ever concerned, I guess.
Yeah, yep, could do that. All right, anybody else have anything to add, either via the chat or the mic?
Can I ask you about the thorax? Because it looks the heart and also the vena cava a bit shrink.
Yeah, no,
it can be secondary due to, the gas within the abdomen that essentially cause a bit of lack of venous return, essentially.
Yeah, I think it's a fair comment. So I mean, just subjectively, that the heart looks pretty small, and the caudal vena cava looks a bit small as well. It's more likely, I think, that this cat is hypovolemic, which is why the heart and the cava look quite small on the thorax, rather than it being directly related to the gas. So there's something going on, something pretty catastrophic that's gone on in this cat's abdomen that's resulted in this pneumoperitoneum, and as a result of that, it's now cardiovascularly unstable and it's hypovolemic, and that's contributing to the appearance of the cardiac silhouette in the caudal vena cava. It's making it look a little bit smaller. All right. Anybody else have any questions or queries about this one? And then I can share the answer with you. All right, so nothing else. So just before we take a look at this cat's CT, so we CT'd this cat's abdomen to give the surgeon a bit more of an idea of what they were likely to find before taking it to surgery. Would any of you guys like to hazard a guess as to what we're going to find here? So we've talked a little bit about what the most likely causes of this pneumoperitoneum might be, and I mean, I've said that the most likely cause would be a GI perf. Is there anything else that you guys think might have caused it? I mean, what do you think might have been the cause of the GI perf? Anything? If you had this case on clinics and then you were just about to open it up, what do you think you'd expect to find? And any suggestions via the chat or the mic?
Gastric ulcer?
Yeah, I think an ulcer is a good suggestion. So a perforated ulcer would absolutely give you this appearance. And ulcers, I've seen most of my perfed ulcers in older dogs that have been on long-term NSAIDs, and I've seen a few in dogs that have been given NSAIDs and then a big slug of steroids. I haven't seen that many in cats, but yeah, a perfed ulcer, absolutely. To be honest, it's pretty tricky to know what else this might be. So let's just take a little drive through the CT scan. So we're going to go cranial to caudal. So we'll take a little drive through it. I'll just point out some of the abdominal organs for those of you who are not familiar with looking at CTs. So I can't use my laser pointer at the same time as scrolling through the CT. So you're going to have to just use your imagination a little bit. So this is the liver we're looking at now, and the gallbladder that's on the right. And then we're just starting to see the stomach here, which is on the left. So we can see some of the rugal folds and a little bit of gas within the lumen. And we're just coming to the edge of the liver. And now we just start to see the spleen appear, which is just here. We've got a little bit more of the stomach as we move towards the mid-abdomen. And now we're starting to see the right kidney, and then the left kidney, a whole bunch of loops of bowel in the mid-abdomen, just the end of the spleen there, just on the left. And now we're starting to see some large bowel. So we've got loops of small bowel with a bit of gas and fluid ingesta in them, and then we've got the large bowel, and then this is just the bladder starting to appear now. All right, so let's go right back to the start, and we'll just take a look, see how the radiographic changes that you've described look on CT. So this is all liver now. So the stomach looks a little bit abnormal. So the stomach wall is a little bit thick and a little bit hypo-attenuating relative to a normal stomach. So that could be compatible with a gastritis or potentially a gastric edema. Now already we can see all of this gas in the dorsal abdomen. So all of the black that you guys can see either side here is just all of that gas that you could see in those abdominal radiographs. And we can see ventrally that there's this sort of streaky hyperattenuation, which represents a small volume peritoneal effusion and an associated peritonitis. So the loss of peritoneal serosal detail and the conclusion that this cat has a small volume peritoneal effusion was absolutely correct. So we've got this streaky hyperattenuation of the peritoneal fat, which is compatible with a small volume peritoneal effusion and associated peritonitis. And we can see that just here as well on the right predominantly. It looks a little bit hazy and a little bit streaky. As we go back, we can see similar changes in the mid-abdomen and caudal abdomen relative to the cranial. So a whole bunch of gas dorsally, and then a whole bunch of peritonitis and fluid within the abdomen ventrally. Okay, so has anyone spotted why this cat has got a pneumoperitoneum? So I'll run through it again, and I want you guys to pay attention to the GI tract. So we're starting to see the stomach just on the left here, and then we're going from the lumen to the antrum, and then just towards the pylorus. If I just swing it back, there we go. So there's the pylorus just there. So it's just to the right of midline. We can see the stomach ending and the start of the duodenum. And like I said, I don't think I can use. Can I use my laser pointer? Yes, I can. Hurrah! So this is the stomach here. So this is the lumen. The stomach kind of comes around, and then this is the antrum. This is the pylorus here, and then this is the duodenum. And there's a great big hole in the duodenum. So hopefully you guys can appreciate that the wall of the duodenum here is not contiguous. So I mean that wall should be complete. There absolutely should not be a gap between the edges of the duodenal wall there. If I just run it on a little bit more, you can see that hole in the duodenum is really pretty big. It continues for a number of slides. So for whatever reason, this cat has got a big hole in its duodenum, and the position is just aborrad to the pylorus. So this is the pylorus here, and then this is the big hole. And let's just run it on, and that's how it looked in theatre. The reason for this cat's large volume pneumoperitoneum and for the associated small volume peritoneal effusion and peritonitis is it's got this great big hole in its duodenum. Now, don't ask me why this cat has this hole in its duodenum. We never found out. I mean, it could be that this cat previously had a foreign body that was stuck there and traumatized the wall of the duodenum. It doesn't really look like an ulcer. So ulcers usually, when you see them on ultrasound and in theatre, the intestine is very abnormal around the ulcer. This just looks like a great big hole. I can't tell you why this happened or what caused it, but I think it's a really interesting case. So this case, really nice example of what a pneumoperitoneum looks like, both on radiographs and on CT, and also a pretty unusual lesion as the cause of this pneumoperitoneum. So what I want you guys to take away from this is not really the CT appearance. That's kind of fun, and that's how we got the imaging diagnosis here from the CT, not from the radiographs. I want you guys to take away how you recognize a pneumoperitoneum. So I want you to remember that gas is going to accumulate in the non-dependent part of the abdomen. So the places to look for it are going to be in the cranial dorsal abdomen and up against the diaphragm typically. So if you can see the margins of the diaphragm really clearly, and you can see the margins of the cranial abdominal organs, particularly dorsally, like the edge of the stomach wall or the kidneys, then the reason for that is because you've got a soft tissue opacity against a gas opacity. So it's making those margins really, really clear. If you see that, then that's a pneumoperitoneum, and that's a big worry. It means that unless there's evidence of trauma or penetrating injury, there's probably gas leaking from the GI tract, and the patient needs an exploratory laparotomy. Yeah, things to take away are how to recognize a pneumoperitoneum. I don't necessarily want to complicate things by talking about pneumoretroperitoneum and the fact that you can get gas in the retroperitoneal space secondary to pneumomediastinum and sometimes as a result of just jugular venipuncture. That isn't the case here. This is a pneumoperitoneum, and hopefully you guys, having seen one now, will recognize it next time one crops up on clinics. So there you go, big hole in the duodenum. Anybody have any questions or queries about case number 3? Okay, so case number 4, and the final case for the evening, is a 10-year-old female neutered crossbreed that presents as lethargic. So I haven't been particularly kind with the history here, not very much to go on. So who would like to give case number 4 a go?
I can take it, Ian.
Great.
Okay.
So let's move on to the first radiograph.
So we've got a right lateral and ventrodorsal view of the thorax, including the cranial abdomen. If you go back to the lateral, please. Thank you. So I think the overall size of the heart is normal. The pulmonary vessels, the cranial lobar vessel seems within normal limits. The trachea looks fairly normal. I thought the external musculoskeletal structures were also within normal limits. On kind of ventral to the cardiac silhouette, I think there is a small amount of radiopaque material producing a little bit of border effacement of the cardiac silhouette, and I think the cranioventral mediastinal reflection is potentially a little bit enlarged. So I don't know if there is maybe a little bit of fluid there. I wasn't completely sure.
Okay.
And I wasn't sure either if maybe there is a little bit of loss of the cardiac waste. But I don't think the trachea is elevated on that area.
Okay.
And then the lungs, I think there is an overall increased opacity, so kind of like a diffuse interstitial pattern, I would call it, I think.
Yeah, I agree.
And then on the ventrodorsal view at 1 p.m. there is a bulge on the pulmonary artery. And I'm not sure if I'm overreading, but I don't know. Maybe the heart is a little bit D-shaped, but I'm not completely sure. I think the mediastinum looks all right, and we could see as well this kind of lung changes. And then the cranial abdomen, I think there is loss of serosal detail in both views. And so I think my conclusion is diffuse unstructured interstitial pattern, considering the kind of changes within the heart. I think probably it's more like a chronic process. So I put idiopathic pulmonary fibrosis on the first differential. I think the differential diagnosis would be some kind of infection or parasitic or less likely neoplasia. The cardiac changes, I think, are probably related, like they are like, looks like the main pulmonary artery is enlarged, or some sort of pulmonary hypertension and cor pulmonale, probably due to the, like, secondary to the lung changes, and the mild, the poor serosal detail and the potential small amount of pleural effusion might indicate right-sided congestive heart failure. And that's all. I think next steps, I would probably do an echo, check for lungworm, and do a BAL if and that's me finished.
Okay, yeah, great. So yeah, I agree that there is a diffuse interstitial pattern here. I think the opacity of the pulmonary parenchyma is increased, but we can still see the pulmonary architecture, so we can still see the pulmonary vessels. So diffuse interstitial, I think, is probably the most appropriate way to describe the changes here. We just need to be a little bit mindful of the fact that this is an older dog, and a slight increase in interstitial opacity is not uncommon in geriatric patients. The cardiac changes, yeah, I could maybe buy that the pulmonary artery looks a little bit bulgy here. I'm not entirely convinced about the reverse D, so I'm not really sure I'd start going down the route of giving this dog right-sided heart disease, but I can't completely rule it out. I agree that there is a little bit of a bulge there between 1 and 2 o'clock, which is exactly where you'd expect the pulmonary artery to be. In terms of the effusion, again, I agree that there is a little bit of effacement of the borders of the cardiac silhouette, but I don't really see any evidence of effusion in this VD view. So there's really no evidence of border effacement of the cardiac silhouette, or any fissure lines, or any retraction of the pulmonary parenchyma from the thoracic wall in this VD. So I'm not entirely convinced that the patient has a pleural effusion. So I could buy that there could be some pulmonary disease here, although it could just be an incidental age change, and I could buy that there could be some evidence of pulmonary artery enlargement here as well. So I don't think an echo is unreasonable, given the history that I've given you, which is just lethargic. But there's something else here that we need to see. So did anybody else see any other lesions in this dog? So this is definitely a spot the lesion case. So there's lots of different sorts of cases that you can get, particularly when you're being examined, and some of them there's tons of lesions, and you have to decide which of the lesions are most significant and most likely contributing to the presenting clinical signs, and which of them you should spend most time describing. There are other patients that have lesions where they're relatively obvious, but you have to come up with a very long differential list. And then finally, there are the where is the lesion type of case. And this is, unfortunately, a where is the lesion type of case.
Is there a lesion on the rib?
There is a lesion on the rib.
Yeah. So possibly something like an osteosarc or something similar on the rib.
Yeah. So
at the costochon, at the the sort of bone cartilage junction.
Yeah. Okay. So we're looking at this area here.
Yeah.
So does everybody see that? So there's quite an abnormal area. It's rib 7, and there's an expansile lesion. There is evidence of cortical lysis as well, and it's just dorsal to the costochondral junction. Now we can see it in both lateral views, and we can see it in the VD view as well, so it's just here. So if you compare the appearance of the costochondral junctions to the adjacent ribs and to rib 7, you can see that there's certainly some evidence of lysis here. So we've lost some of the bone associated with that rib. So we've got what looks like a monoastotic, aggressive bone lesion associated with the costochondral junction of rib 7 on the left. So something sinister has to be on the differential list. So osteosarcoma, chondrosarcoma. So absolutely, the rib lesion is the thing that I wanted you guys to see here, and it's just here in the right lateral view. It's here in the VD, and then it's here in the left lateral view. Okay. Yeah, always check the ribs. There is another lesion here as well. I wonder if anybody has spotted it. So the rib lesion is the main event here. It is tricky to see. Rib lesion. Anything else that anyone might have seen? And you can contribute on the chat as well as on the mic if you're feeling shy. So immediately that we see this rib lesion, and it looks nasty. So it's lytic, so it's aggressive, and then there could even be an irregular periosteal reaction here, because it's on a rib. We're thinking, well, we've got this aggressive bone lesion. It's on a rib. It could be an osteocyte, could be a chondrocyte. It's probably something nasty. We're going to FNA it, but we also need to be concerned about the possibility of pulmonary metastasis.
Is there a nodule just in front of it and above
it? There is a nodule. So there's a little soft tissue nodule just here. Now, I can only see it in the right lateral view. I can't see it in any of the others. But the fact that we've got a soft tissue nodule and this aggressive bone lesion means that the pulmonary mets have to be on the differential list as well. Now, a solitary pulmonary nodule is non-specific. So this nodule doesn't have to be neoplastic. It doesn't have to be a metastasis, but it certainly could be. And we can't completely rule it out. So the lesions that I wanted you guys to pick up here are this rib lesion. And the thing to take away from this particular case is always check the ribs, and also this very subtle pulmonary nodule here. So that's a tricky one. And that was very much a where the hell is the lesion kind of case. So yeah, nice job, everyone. Does anybody have any questions about case number 4? All right. Okay, so that is all 4 of our cases for this evening. I hope you guys enjoyed discussing them with everybody. And yeah, we will be holding another of these film reading sessions next month. So the idea is to do them monthly and the last Wednesday of every month, and same routine next time. So we'll send the cases out a week before, which will give you guys a chance to review them before we discuss them as a group on the Wednesday evening. So does anybody have any other questions at all about any of the cases that we've discussed this evening? Okay, well, in that case, I will wish you all a very pleasant evening. I hope everybody is well and is staying safe, and hopefully I will speak to you all again in a month's time for May's film reading evening. Thank you very much for attending, and yeah, I will speak to you all very soon.
Thank you very much, Ian.
No worries.
Thanks,
guys.
Great session.
Thank you. Bye-bye.